underneath here is some connective tissue. And you can see it's showing right there. Okay, so we go to the palate, it's the same case. We take, this is our donor here, this is the tissue, this is the tissue taken, and that shows just how much is the thickness. If we get the graft 5 millimeter, for this purpose it's wrong. You want a 1 millimeter and a half to 2 millimeter thickness. And here's before and after. Okay, is this case is going to stay? If patient is going to be having poor oral hygiene again, we're going to lose that tissue. Okay, another case. We have recession, and we have a little bit of a cleft right in here, and this is a CJ almost. So let's treat this case. We go from the side window. If you want to go insert the tissue from here, and you have difficulty, we make a little incision here, flap the tissue, and release the tissue. So you see how the tissue moved down here to before, right? Just move it frontally. Now, graft is taken, put the suture through it, and then pull it inside, underneath the tissue. So here's the graft, part of the graft is showing. That gentleman there is, asked question that this connective tissue is not supported by anything, but it's going to survive, and it's going to epithelialize from the epithelium from around the area. What would be the nature of that epithelium? It goes to origin of the epithelium that it had before. But clinically, are we concerned about that now? All right. There's before and after. Another case. The difficulty, no vestibule exists here. And crown was made, huge recession. I used tetracycline to clean the area and root cleaning. And then here's the size of my graft. Before I put the graft under here, you can see how big it is. So what we're going to do, we're going to slide it in. Sometimes you have difficulty. Sometimes you have to really pull it in with the suture. And sometimes with the instrument you can put it in. Depends how flexible is this tissue here and how much you flap it. And you have to be careful. When you go in there, you flap the tissue, make room for your graft to go in there. You can detach the papilla, which I have done it, but I'm not intending to do that, but it would be better to have the right instrument and how to use that instrument and not rush through it. All right. So the graft is placed in. And here's before and after. So another case. What causes the recession here? Beautiful. You guys familiar with this?
Yeah.
My assistant familiar with this. This beautiful veneers and crown. But look, patient didn't like that. And look, this patient is flossing very hard. It's creating cleft with the old flossing and the wrong flossing and holding the floss wrong. You have to wrap the floss around the tooth, otherwise it's creating a lot of cleft. You wrap the floss around the tooth and you go up and down. Okay, so, tissue is taken from the palate, connected tissue and placed right in here. Are we concerned about a little bit of exposure of the connective tissue? No. But sometimes if my graft is very thin, I am concerned I'm going to bring this tissue down and cover that. Okay, so before and after. Now this patient spent, how much did they spend for each veneer, Nancy?
I would, from the back to the finish, I would say like about an hour.
No, how much is the fee? How much is the charge?
Oh, it's in our office it's about $1,400.
$1,400. Patient pays, okay, $1,400. And then end up with this. It's not pleasant. Not for the doctor. And this doctor is very conscientious about the graft. And talk to the patient, prepare the patient, and he believes that this should be correct. If you don't believe it, when you talk to the patient is not going to buy it. Like anything else. What do we have here? Plaque and huge recession. We did the graft right in here. We can see tissues forming in there. So before and after. So is this graft is too thick? Yes, but it doesn't matter. Sometimes we can go shave it from the top. If patient says, you know, it's too bulky, we can do it. But we better, before we put the connective tissue underneath, we shave it a little bit so it would be, won't be too thick. So the amount of root coverage. The best root coverage you can get, the best root coverage is what? Coronally positioning flat with the connective tissue. That's the best root coverage. You can almost, if you have a good patient, if you have a good area, if you have the 1 millimeter of attached gingival left, if you have a good donor tissue, if you know how to do it, believe me, you can get 100% coverage. And I'll show you several cases. So complication. We always have complication, infection, bleeding, and so forth, so we have to check medical history before we do it. If patient takes couple Motrin, sometimes we have problems. Right, Todd?
Yeah.
That problem. With just patient taking Motrin, 800 milligram ibuprofen. And it bled, and I had to go Sunday and take care of it. So, no aspirin, no omega-3 fish oil capsule, since the blood thinner aspirin. You know, patients on Plavix or any blood thinner, you have to worry about that. And the post-op instruction is important. If patient is a boxer, you tell patients, you know, no boxing, no swimming, no scuba diving, no hand gliding, no airplane riding, and so forth. So historical thing. Basically, the first graft was done in the United States by N.P. Younger. It's presented in the American Dental Club of Paris. And then in 1963, Helding Braun Byron from Scandinavian country in New York presented pre-gingival graft technique. So the procedure is just how many years, you know, it's just 100 years old or so forth. But it has been increasing and improving and everything. Now, we want to do a graft. We have multiple, what do we have here? Multiple torus, palestine. So we have tori here, we have another tori here, we have one here, then we have one here, then we have one here, then one here, then two little one here, one little here, then one here, one here. So when I'm going to take my tissue, so before I do that, I do graft, I check the palate, make sure that I have a good donor. How do I check the thickness? I really can't. In Germany, they made a tool so you can measure that, but you know they didn't continue making it. And I wrote the letter and wanted to have it just for a slide, and I couldn't get it. So anyway, so in that case, what we're going to do if we need to do correction of recession? Very good. Another periodontal. All right. So we're going to use perioderm, alloderm, etc. There are all every company comes up with that, with collagen from enough cadaver. Okay, some people because of religion or because of other reasons, they don't want to have that. Then we go to animal collagen. But if they know it's animal collagen, they don't want to have that either. Then you don't have any choice. There's no donor in the mouth, and they don't like this material, so that's it. So alloderm or periderm is better. It gives you even consistency. Alloderm, I see sometimes it's different, haphazard, and a different thickness and so forth. So I like perioderm better. Okay. I'm not getting paid by either of these companies, so please. So now we have recession here. We have recession here, we have recession here. And then we are not having a donor. So what we're going to do, we're going to use these cadaver collagen, acellular. So we expose the area. The reason I did that, I didn't do it closed, because I wanted to show. Whenever you see recession is up to here. That much, same amount of recession, there's no bone. The root is exposed. You can't see it, but it's exposed. So, root planing, cleaning it. When you use the cadaver collagen, you put on the blood. The side that absorbs more blood, you want that side to be toward the tissue, not toward the exposed. So we place it and suture it, and then here's the corner. All right.
Very nice.
Do you get best result with human tissue, with the patient tissue? Obviously. But that's alternative. Okay. So one of the difficulties we have in recession, when we have recession interproximal, the hole between central. Patient comes in and you make a beautiful 2-porcelain crown, come back 2 weeks later, says, doctor, everybody comment about the crown you did for me, it's beautiful, but this hole everywhere, what is the hole in between? What can you do? The tissue shrunk there, and you pack the cord a little bit, you push the cord a little bit harder in there, tissue was thin, temporary was irritating the area, combination of these things, the tissue between the central 8 and 9 now is gone. It's an ugly situation. And every paradigm is trying to come up with a consistent and reproducible technique. We have not been succeeded yet. For those of you who want to do some research, I was planning to do this research to try different techniques and see which technique works better. Now look at this. This lady works for Disney. She's designer for Disney. Very intelligent lady. She went to hygienist, and hygienist did the cleaning. There was a lot of inflammation, and some recession happened. Now what we're going to do? She said, I don't like it. So what we did is, we corrected this area here. You see between the 7 and 8. And I tried to correct on this one. I did the same thing. It didn't work. So we don't have reproducible techniques. In this case here, what do we have here? Recession on central, on lateral, and recession interproximal. Calculus, the extension of inflammation. So, and recession on the palatal area. So I did a graft right here, and then moved the graft coronally. And I did this like a little sausage, like this. It's going from the palate to the buccal, right underneath the tissue. So, and you can see the tissue from the palate going underneath this and pushes the papilla down. And this is that. Can I get this result for every case? No. So before and after. Before, after. This is another technique I use to do it here, and this is everything is connected at the same time you move, except for 2 incisions right here, and I move the tissue down, and I put connective tissue underneath into interproximal area. This is really challenging in the present time in our field of perio. So here's before, after. And this is like 2 weeks post-op, we can see the incision, and I move the tissue down. And you have to be careful if 2 incisions close, you might lose the tissue. So, okay, advanced grafting. All right. We are not going to show you that. Okay, we are finished. Do we have any questions? Yes, sir.
Well, we have those big grafting procedures from the palate. Are we at risk for paresthesia or numbness?